Greg asks, there are too few measures for my specialty, so how can I make a MIPS submission that doesn't earn big negative adjustments?
A great question, Greg, and a common problem. 6 submitted measures typically defines a complete MIPS submission in the quality performance category. But CMS understands that not all specialties can find a full complement of 6 applicable measures. There's still some holes in the system, but there are at least 4 net mechanisms built into the rules that can help you. First, look at specialty measure sets. For 2022, there are 47 specialty measure sets into which sort 196 measures. The number of measures that sort into each specialty ranges between 2 and 62. 42 specialty measure sets contain 6 or more measures. 5 specialty measure sets contain fewer than 6 measures. These specialty measure sets are guides. You don't have to prove specialty certification to use any of the specialty measure sets. You should be guided by the scope of your practice. If you use a specialty measure set, you don't need to go outside that set to choose your measures. If there are fewer than 6 measures in the set, if you submit all of the measures in the set, your measure set is deemed to be complete, and the denominator for your score is reduced, eliminating any penalty for a short number of measures. Second, look at EMA. EMA stands for Eligible Measure Applicability. In EMA for 2022, there are 42 measures that sort into 12 clinical topics. Each group of measures mapping to a topic is considered an EMA cluster. If you submit all of the measures in an EMA cluster, and only the measures in an EMA cluster, your measure set is deemed to be complete, and the denominator for your full score is reduced. You can find the EMA clusters defined in a document in the qpp.cms.gov website. Third, look at QCDRs. QCDR stands for Qualified Clinical Data Registry. Don't mistake this for a qualified registry. Apologies, Medicare, I think, tends to use the term registry a little overmuch. But Medicare's intent is to use the QCDR structure to encourage specialty-specific organizations to build and deploy measures specific to their specialties, and not have to go through the full measure acceptance mechanisms that are required to bring measures into the public menu of MIPS measures. There are still measure validation requirements, but there's an expedited acceptance and a limited deployment. Your specialty may have QCDR measures suitable for you. Fourth, if all else fails, apply in advance of the submission deadline for an EUC. Or apply after the submission deadline for a targeted review. EUC stands for Extreme and Uncontrollable Circumstances. In this case, the uncontrollable circumstance is the lack of applicable measures. Now, I've not seen CMS reduce the measure requirement in response to an EOC, but if they accept your rationale, they can eliminate the quality measure requirement, distributing the quality points to the remaining applicable performance categories. A targeted review is intended to be used after the preliminary results for the year's measurements are announced and to ask for an adjustment to the scores. In this application, you document the reasons that more measures did not apply. CMS may or may not agree with your assessment. If they agree, they will grant denominator reduction and calculate a full potential score on a smaller number of measures. Let's review the weaknesses. First, for the QCDR. You're never required to consider QCDR. It's a little outside the MIPS mainstream. QCDRs are typically specialty specific. Each QCDR deals with a small subset of the entire MIPS eligible provider population, and with much of health tech being volume driven, they often have limited capabilities to get data. If your requirements fit their capabilities and you like their measures, and the measures are applicable, it can be a great choice. Second, the weaknesses of targeted review. The weakness of targeted review is that it is after the submission deadline. You're already at risk of a low score when you ask for a review, and you risk being refused. Third, weaknesses of EMA and specialty measure sets. They share the same downside that even though some of the measures in the set might be applicable to you, you still may not be compatible with all of them or with enough to earn a full score. Measure compatibility with your practice has two factors: eligibility and applicability. Eligibility is easily measured. Every measure has specifications that determine which CPT codes and ICD codes in a billing data set make a patient or a visit eligible to be included in a measure. When the number of eligible instances equals 0, you can't use that measure. It's easy to prove, it's indisputable. You just don't have enough eligible instances. A vendor like Mingle Health can help you evaluate your whole billing data set and document the proof that you need of the lack of measure eligibility to support your EUC or your targeted review application. If you're using an EMA or specialty measure set, you identify those measures with a zero numerator and a zero denominator. Mingle Health or your registry vendor does that for you. It's harder when you have eligibility but not applicability. That means you have patients and or visits with a ICD and CPT codes that apply to that measure, but the care the measure represents is not part of the scope of your practice. This happens a lot. There's no hard data to support it. You can lay out your perception of the case in an EUC or a targeted review application, but the decision by Medicare will be more subjective than it is in the case of eligibility. In summary, MIPS success in the face of inadequate measure availability can be as difficult to document as measure success. You may need professional help like that available at Mingle Health. Thanks. Great question.